What's up, everyone? Welcome back to the lounge. I'm here with my amazing co-host, Dr. Adam Green. How you doing?
Good. How are you?
Why are you looking at me like that? Who's this guy in the middle?
Oh, I'm Michael Bonk, one of the
Whoa, hang on. Make the guests introduce themselves.
Well, he's been on before.
Matters.
He's been on before. So, all right, this is Dr. Bonk. He's home crit care trained, but like myself, just does critical care medicine. He is the program director for the Fellowship of Critical Care Fellowship at Vineland, and is one of our ECMO attendings and colleagues at Cooper.
Is, I think, the tallest intensivist that we have. Is that true?
in our group.
In our group.
I believe so.
Oh, yeah, not in the world.
How
No.
tall are you?
6'3", a little bit of change.
What? A little bit of change.
Yeah.
Most people who are short, they look for extra, and you are already above average, and you're still adding stuff. Why do you do that?
If I could subtract, I would. But unfortunately, this is where we are.
Look at the gall on this guy. So we brought you here today to talk a little bit about steroids.
Mm-hmm.
Steroids. I don't know did everyone have a chance to see the cover image of?
That's one of those photos.
Something.
Yeah.
When I'm having a bad day, I'm just going to pull that up.
Isn't it great?
Yeah, absolutely.
We spared you. We spared you the embarrassment, but I couldn't help but poke fun at Adam. Actually, Adam is the better looking one of the. I think Adam did better with that one. Not next time, though.
I got a lot more hair in that than normal, though.
So why don't we start talking about some steroids, Adam? What do we got?
Cool. So I think we order a lot of steroids, and there's different practices. And I think if I were to ask you, someone with COPD, what do you do? Someone will say 42.6 is all you medrol.
Mm-hmm.
And ARDS is different. And I thought we would just take some time, go through just different disease entities that we use steroids, maybe some controversy, whether we should or shouldn't use it, and just really try to be practical in terms of like dosing, what you think about, how you stop it. And we'll definitely talk about studies, because I think this topic of any of them, we have to start talking about some of the trials. But I really want to know like what you do, because I think I have my own practice pattern, and it would be just interesting to hear your thoughts. Is that vague enough? I think
Yeah.
that's good.
And I think one thing we should have done, and this is my fault, is explain to anyone who's new here on the show what we do. Really what we do on the show is we get experts on, not to talk about the hard science or recite what's in the textbook. These are really the gray zones of medicine, the things that there are no right answers to. But we brought you on because you're an expert in this field, and we want to hear what you have to say, how you use it in our practice, and then we'll pepper in our commentary and rip you apart.
Yeah. So we chose a very non-controversial, straightforward topic.
Exactly.
Like
The least controversial topic in critical care would be steroids, and we thought this would be a great topic to talk about.
Perfect.
All right.
So let's just start with the first slide we'll pull up. And the question is just, you see I made some slides. The question is just, you hear the terms corticosteroids, glucocorticoid, mineralocorticoid, I can't even say it all, and all of these different ones. Can you just give me your like 30-second or 15-second overview of the different types and your thought process?
Yeah, so I think about corticosteroids predominantly in two different ways. So the first is, like you were alluding to, the glucocorticoid action, which is going to be mostly like your immunomodulatory effects, and then also gluconeogenesis. That's going to be where you start to see hyperglycemia. And then you start to think about the mineralocorticoid activity. So that's going to be more fluid retention, sodium retention, potassium excretion. And so all the steroids that we use clinically fall along this spectrum, where we've got dexamethasone, which is almost entirely glucocorticoid activity with almost no mineralocorticoid activity. Then we move into prednisone and methylpred. That's going to be about 70% glucocorticoid, 30% mineralocorticoid roughly. Then you get to hydrocortisone, which is basically it's 50%, like 1-to-1. And then you move into fludrocortisone, which is going to be almost entirely mineralocorticoid activity. And so just as far as the mechanism of action, that's how I think about them. And then, oh, sorry.
No, I was just going to say, for people at home that are wondering, what steroid would give you these results?
That's always.
All of them? All
you have to say at the same time.
Okay, gotcha.
Yeah.
Sorry. Great summary, though. Thanks.
And then I think about mechanism of action, right? I think when you look at the short acting, that's going to be like your hydrocortisone, which is going to be a half-life of about 8 to 12, as you had on that slide. When you start thinking about prednisone and methylprednisolone, that's going to be more the 12 to 36-hour half-life. And then you have much longer acting like dexamethasone, which is going to be more 36 to 72 hours of a half-life.
That's awesome. And I'm just thinking, I've never done this before, but since we have Firth watching and fact-checking us, I want to ask him, I know dexamethasone is the longest acting, and I know that really it can be once-a-day drug. So when we have these neurosurgery patients with cerebral edema, or ENT patients, why are we ordering 4Q6 that we do all the time? What's the science there?
You
So
mean
I'm hoping he types an answer.
You mean we like everything. We or why neurosurgery does it?
Yes.
I gotcha. All right. We'll see what he says. We'll put his answer up when he jumps back on the screen.
Cool. So I think that's a great overview, and I think that helps me some. And what I took away from it is, for the most part, when I'm using dexamethasone, doing it once a day is probably fine. When I think about Solumedrol, I think about minimum doing it twice a day. And I think we've talked about that. So if I have someone who's on 40 prednisone and I decide I need to switch to IV, I would do usually 20 Q12 of Solumedrol. And I just generally don't order it as a once a day drug for that reason. So I think enough of that. Let's jump into kind of the first topic, or the first case is how I did it. And so let's pull that up. And Haney, I'm going to have you read the cases for us. I made them specifically for you.
Because I know how to read. All right. This is case number 1, a 75-year-old diabetic male.
Yeah.
DM is diabetic male?
No, 75 male.
Yeah, male. Diabetes. Maybe I'm the one that has trouble reading. Presents with fever, a non-productive cough, and dyspnea. There are sick contacts at home. He has a dog named Steve.
Yep.
Interesting. I don't know if that's a red herring. You want me to go through the white count? What am I, a medical student here? People can't. All right. The white count's 4. It's 14 over 40 for the CBC, for the H&H. Platelets are 322. Neutrophils are 55%. Lymphocytes are 35%. Other, 10%. BO creatinine is 50 over 1.2. ESR, CRP. Yeah, why bother? Did you put a procalcitonin on here?
I did. That's exactly why I'm happy.
Worthless. Can I tell you guys a story? The procalcitonin people have found my videos on social media, the company, and they harass me. They harass me in the comments and in the DMs. So procalcitonin sucks. No calcitonin is what I call it. All right? All right, go ahead.
And of course, procalcitonin is 0.6.
Of course, it's worthless. It's a worthless test.
So the whole point of the case was to then, and we saw the chest x-ray, which had a right lower lobe infiltrate, is to ask the first topic, which is obviously about viral pneumonias. So I guess my first question is, what screams viral pneumonia about that? And what is your mind differentiating viral versus bacterial? And does everyone get antibiotics just because they have a pneumonia? Or what's your approach to these patients?
So I think to Haney's point, the first thing I would do, if you're really worried about bacterial pneumonia, you shouldn't use procalcitonin as a way to determine whether you should be starting antibiotics or not. So you should be starting antibiotics if you're concerned. So I'm Team Haney for that one.
Thank you.
Now, if I'm suspecting that it's a viral pneumonia, I may use procalcitonin to guide my decision-making from there. So particularly for this case, there's a leukocyte predominance. There's no leukocytosis. From a symptom standpoint, you're thinking pharyngitis, conjunctivitis, irritation of the mucous membranes, fevers, chills, things along those lines. That would be pushing me in that direction. The chest x-ray didn't show the dense consolidation that I'd be expecting with a bacterial pneumonia. If we had a CT scan, you would look for things like tree and bud opacities. So anytime I'm seeing tree and bud opacities, I'm thinking one of 3 things, right? So it's either going to be non-tuberculous mycobacterial disease, it's going to be aspiration, or it could be a viral bronchiolitis. So those are generally the things I'm thinking about.
Perfect. Yeah, and I think I do the same. If they're super sick, I usually give antibiotics. If they're on the vent and I'm really worried, then I do. But if I have a culture that says it's RSV, and it fits RSV, and they have lymphadenopathy and pharyngitis, and their kids are sick and they have a newborn, then I'm bold and I try to not give antibiotics. But yeah, that's great. So let's talk about steroids, because that's the whole point. We're 10 minutes in. Let's just start with COVID. So what are your dosing for steroids in COVID? And I want to avoid ARDS. We will get to ARDS. So just pure COVID, how do you approach it in terms of steroid use?
I really base it on recovery. So that's the trial that I'm usually thinking about. If somebody's admitted, and honestly, if they're coming to us, they're on oxygen, right? So anyone that's on any sort of supplemental oxygen that's hospitalized, I'm doing recovery dosing, dexamethasone, 6 milligrams daily, 10 days.
So these are people with real disease. So if they have a swab that says positive COVID and they have clean chest x-ray, and they have no respiratory symptoms, you're not starting it. But someone who has infiltrates and you think has pneumonia, you're doing 6 milligrams of dexamethasone once a day for 10 days, and that's what you're doing.
How much hydroxychloroquine are you using?
All of it. Yeah.
Thanks. A big bag. And then how about non-COVID, non-influenza? I'm saving the best for last.
Yeah.
What's your approach? Do you give them steroids ever?
If they have an underlying indication, if a patient's coming in with asthma and you're worried that this viral infection's kind of tipped them over into an exacerbation, If they have COPD, same situation. You're worried that you're getting a flare of their obstructive disease. I'm definitely starting steroids in those patients. But you also see bronchospasm in patients that don't have underlying obstructive lung disease.
Yep.
So like with human metapneumovirus, parainfluenza, if I'm noticing wheezing on exam, those are patients I'm also reaching for steroids with. But it might also be a situation where we need to look more into steroids in those patient populations based on what we've seen with recovery.
Cool. So basically, you want to order steroids. You're just trying to figure out a reason to allow you to do it.
I'm basically reaching for steroids in almost any situation I can.
I think that's cool. And I think, Haney, I would be interested in your thoughts too, because I'm just thinking about this. Like, as adult physicians, we're so used to saying, do you have asthma? Do you smoke cigarettes? No bronchospasm. But as an ER doc, especially during RSV, you probably see RSV, bronchiolitis and wheezing in these kids all the time.
Yeah.
And you're probably used to giving them inhaled steroids and trying to, and that's just like, it's just not the way we're wired. Like, we're not used to seeing that type of wheeze.
Yeah. And I'll honestly, someone comes in and clinically, they are having reactive airway disease. So from whatever the cause is, I have a very low threshold to give it because if nothing else, people just feel better getting a breath in. Like, my daughter had a pretty bad upper respiratory infection and it just wasn't clearing up. I like put my ear in her chest and she's wheezing and she doesn't have asthma. And I was like, it's fine, whatever. And after 3 weeks, I was like, take this kid to urgent care. So we went to urgent care and the doctor's like, we'll put her on steroids. I was like, yeah, but she doesn't have asthma. They're like, just wait. And 2 days later, like instant, the kid felt better, not just like mentally better, but like the wheezing was gone, everything was better. And so I think there's, even if nothing else, symptomatic control, but obviously we're talking about critically ill patients that do need to have their airway managed, and just that release of the bronchospasm can be very helpful for management.
Yeah. And what I think, and I'm sure we're going to talk about duration too at some point for some of these patients, but like what you're saying is you're giving it for a symptom, not because the order says prednisone times 5 days. So if you have really bad bronchospasm and it's longer than 5 days, I'm assuming you continue the steroids, right? Or you do 5 days and then you've hit your allotment of steroids and you stop.
I think it depends on the disease process. So if it's COPD, I'm very much a 40 milligrams of prednisone for 5 days and cut it at that point.
Really?
Yeah. If you've got a patient that has no underlying obstructive lung disease and they're just now presenting with it, I probably would do a longer till they have a resolution of their symptoms.
Interesting.
And same with asthma.
Yeah. How about you, Dr. Green? Sounds like you.
I don't know the answer. I always get worried whenever I see something that's absolute like that, then I think it must be wrong sometimes. So maybe there's evidence and I just don't know about it, but I feel like we do prolonged tapers. I keep the steroids on. If it's real wheeze from bronchospasm, then I don't know.
Yeah, makes sense.
Yeah. And then, yeah, we don't need to get into that. Okay, cool. Now let's talk about influenza. So are you using steroids for influenza or not? Probably the most controversial topic in this whole session, but what do you think?
So if a patient's coming in with pure influenza pneumonia, doesn't have any other indications for steroids, I'm not reaching for them. And, that's based on the Cochrane Group's meta-analysis, Cochrane evidence. They do a really nice job. I think the caveat I would give to that is a lot of the trials that they looked at were during H1N1. They're not randomized, double-blinded trials looking at influenza. So even though I'm not reaching for it, I think it might be something worthwhile looking into again in the future. And interestingly enough, Dexa ARDS and Cape Cod, neither of them excluded influenza.
So let's go through that one more time. So there's a bunch of retrospective studies for influenza and steroids. Some showed harm, some showed safety. They did a meta-analysis, and the overall impression was harm. Okay. So that's, I think, and that's what I did pre-COVID. Has COVID changed your impression at all in terms of steroids and influenza? Because it's changed mine, and I'll explain.
Yeah, it's changed my opinion in that I think it's worth revisiting, although it has not changed my clinical practice when it comes to steroids. And it's
very diplomatic.
Yeah, try.
So my thought is, number one, I don't think steroids are harmful, especially in this group, and that in the beginning of COVID, there was a signal that steroids were harmful. And then when we actually had randomized controlled trials and really looking at it, the evidence was overwhelmingly positive that steroids are good. And so I'm extrapolating the severe influenza. So I will give my severe influenza patient steroids.
You're on the record.
Yep.
All right. That's cool. Yeah, I'm probably more in like Bonk's camp, to be honest with you. Not because I disagree with you. I was waiting to see what you say. I'll just say the opposite. Yeah. It's been the key to my success. What you're saying is very reasonable. I just think we just need that trial. It's hard. It's hard for me to give it with the evidence as it stands right now, saying that there's potential harm. So what I would do right now is I would wait for the person to maybe get past that viral phase, because I guess that's the thing that's most worrisome is the viral replication. And once we're past that viral replication stage, if the person is now having florid ARDS, I would do it more for the inflammatory component.
Yeah, which is just
that a bit of a hedge? Or
yeah, it's a hedge. I also think that there's some evidence that if you're going to do it, you should do it in severe cases and you should do it early.
That's fair.
And I just think it's interesting because we give steroids to everyone at crazy doses.
Yeah.
And this is the thing where they're like, nope, this is where we're making a stand. Like, we'll give it to everyone else. Like, everyone else. You have one rheumatological serology that's positive, so you get a gram of solumedrol. But this is the one where we're like, we're not doing it.
Well, of the three of us on this couch, who does the most research?
I got to get on it, I guess.
Well, it sounds like you have some work to do.
Yeah, I wish someone had thought of this question earlier. But yeah, I don't know. Maybe I'm wrong. But
let me throw. There's a little bit of delay on the stream, but Firth put up the question. Let's see. Oh, he said a few things. Let's get some. So Firth said, old literature says anything greater than 10 milligrams at a time of decadron given IV could cause perianal itching. You don't need that.
Whoa,
you don't need that in your life, right? All right. The next time neurosurgery recommends that, we can bring that up. Because do you really want your patients with perianal itching? Let's see. We also have. Adam, you're gonna like this.
Yeah, let's proofread it first before.
No. We don't proofread anything. Don't tell anyone, but I agree with Adam on using steroids in influenza. I use XARDS without hesitation.
Well,
now, if Firth says it, then I'm okay with it. I can buy that.
We're not talking about ARDS.
3-1.
Okay, that's it. So we're not talking about ARDS. We're just talking about severe influenza.
Yeah, severe influenza.
So
No
you're
shock,
saying
no
without
ARDS.
ARDS.
Yep, I do it.
You still do it.
Yep.
All right, Firth, what say you? Or anyone in the audience, please put your comments up there and we'll throw it up there and we'll keep discussing.
And we should say this is the point of the lounge. And I think it's probably one of the best things that we've done is that, like, there's not supposed to be a right answer, because if there was, then we would just say it and move on.
Exactly.
That, like, different people have different practice patterns. But I think maybe this is a good time to talk about it. What's the downside of steroids? Because there's a lot of fake news out there about what the harm can happen. And so maybe you should just discuss that a little bit. What are you worried about? Who do you not give steroids? Are there contraindications? I don't know.
Yeah, no, I think a lot of the concerns I think that we have are based on trials looking at like whopping doses of methylprednisolone in septic shock that were run in the 80s. And so you saw a lot of negative outcomes that came out of those trials. So higher rates of renal replacement therapy, worse outcomes with ARDS, higher rates of superinfection, fungemia. And I think a lot of those concerns propagated to our clinical practice today. Whereas in actuality, when you look at the doses that we're giving, like hydrocortisone 50 Q6, hydrocortisone 100 Q8, the main thing that I worry about is hyperglycemia. But other than that, there aren't too many downsides that you would see at the bedside.
Yeah. Because I think, and I might be wrong, I'm sure that someone will tell me, but I think like 50 Q6 of hydrocortisone is about 40 of prednisone. I think those are roughly similar in terms of dose equivalents, which we give 40 of prednisone to asthmatics and COPDers all the time as an outpatient. But yeah, I remember training where if you had GI sepsis and were in septic shock and they had some surgery with a wound, we would not give steroids.
Yeah.
And I think that's like really hyperglycemia is all we're worried about.
Yeah.
And maybe your bone health in 30 years.
Yeah. But the other thing was that people getting off the vent, like they're not going to get off the vent. They're going to have diaphragmatic weakness and myopathy and stuff like that. And that was true for the prolonged courses of steroids, but we're not even doing that anymore.
Yeah.
So, I feel you.
It's cool. Good.
I agree with you, Adam. I agree with you.
We're making progress.
We're good. Super good. All right. Let's do another case then.
All right.
I think we've exhausted the influenza.
Do you want me to read this to you, Adam?
This one's for you.
Okay. Case 2, same patient. That was the 75-year-old diabetic, but now with a white count of 25, productive cough, and 12% bandemia. He's unfortunately a Knicks fan. That's not nice. That is not nice, because if anyone knows me, and being a longtime New York City person, the Knicks have broken my heart yet again. That would be 48 years in a row that they broke my heart.
I would say the slide was created before the loss last night. So it wasn't meant to.
So you were just being
obnoxious.
Just being obnoxious. And how did the Sixers do this year, by the way?
We're not here to talk about the Sixers. We're here to talk about the Phillies.
They lost to an inferior team. So what are we talking? And then we have a CT here, which shows intentionally not ARDS. It is not bilateral. It has a lobar infiltrate.
Yep.
And so you're more concerned now for, I'm trying to lead you to a bacterial pneumonia, and we'll say community acquired, just to be simple. And so really, I'm leading you to give me your thoughts in terms of steroid use in community acquired pneumonia.
So it's interesting. I'm sure you guys had the same experience. So when I was a resident, we were giving steroids for community-acquired pneumonia all the time. So we were doing, if I remember correctly, methylpred 40 milligrams twice a day. And then through my training, we had the changes in the IDSA guidelines, no longer recommending steroids in community-acquired bacterial pneumonia. But now, with Cape Cod coming out, I think that's also changing. From my practice standpoint, I'm definitely moving more towards hydrocortisone in these patients.
And just remind me, so Cape Cod was hydrocortisone 200 milligrams a day, is that right?
Yeah.
And it was for, I don't remember, 7 days, and then they could pick either 8 or 14. Like, I don't remember
I think
exactly.
if I remember correctly, you got to day 4, and at that point, depending on how they were recovering, you would either go to 8 days or you would go to 12 days with a taper included.
Yeah, I'm going to disagree again. And I don't know if I give steroids to this group of patients. And maybe I'm being a hypocrite for bacterial pneumonia.
Okay.
And part of the reason is I don't love the Cape Cod study. First off, their anticipated mortality was significantly less than what it really was. I think the groups were like 6% versus 12%. And the number needed to treat was like 18. And I just don't know if there's enough clinical justification, if that's a big enough difference for me to jump to it. And the other issue is that it was then underpowered in terms of what they anticipated. Of the patients they screened, like 85% of them didn't get included, and only 75% or 75% I think completed, or no, I'm sorry, 25% actually completed it. So it just felt like there was a lot of holes in the study to convince me that I needed to change.
Yeah.
So I have not been doing it in that group of patients.
So just so I understand, for influenza, there's no data, but you use it. But for Cape Cod, there's actually a study that you've picked apart to show that there's no data, so you don't use it.
That's correct.
Very convenient. You sound like a researcher.
That's absolutely correct. So anyway.
It's interesting, too, because the ESCAPE trial came out roughly the same amount of time. They found no difference looking at methylprednisolone versus placebo. But we always think about methylpred as being like the lung steroid, right? It's got better lung penetration. Like we think of dexamethasone as being the CNS steroid. Just interesting.
Yeah. Firth has come back and said, oh, wait a minute. Okay, we'll take that comment up. We'll get to that in a second. But he had said, I will use steroids in influenza, Adam. Old studies showing harm are pretty poorly conducted, as you said. Also steroid dosing in those studies, if I remember correctly, were much higher. Interesting. If Firth says it, I'll believe it if Firth says it.
There you go.
And then Firth also says, I'm not screening any of these. I'm just reading them off. So please don't put anything that's going to get us banned on YouTube here. This is getting scary. I agree with Adam again on the How much have you paid Firth to be on this show?
Undisclosed.
Is he the new Randy?
Yeah.
Is that what's happening?
Yeah, he's the new Randy.
He's the new Randy. Do you know about Randy?
Oh, yeah. I trained Randy.
That's awesome.
You're responsible for Randy. We love you, Randy, if you're watching. All right.
So that's cool. I like that.
You like that he agreed with you? Of course you do.
I mean, yeah, I feel good about myself right now. But interesting stuff. Anything else to say about community-acquired pneumonia and steroids? I think it's, again, up in the air, and I don't know if I have an answer for you.
And we need more trials, like almost everything.
Yeah.
It's easier when they're in septic shock. That's an easy decision.
Or ARDS, or wheezing, or whatever.
Yeah, exactly. I want to do another case?
Yeah, let's go.
You want me to read to you again? Also a 75-year-old man presents, does he have diabetes too? Presents with flank pain, fever, acute kidney injury, hypotension, refractory to resuscitation, and also has lactic acidosis. The blood cultures are positive for gram-negative rods. He went to high school with Haney.
I just thought it was. I've been on service for a long time, and I did this last night. I thought it was funny that this guy's 75 and he went to high school with Haney, and I think
listen, chronologically, I am the oldest, but phenotypically, I look the best. So I don't really care. All right, so
we'll chalk these into the jokes that I think is funny, but no one else watching thinks is funny. We have a long list.
We can pull. We can pull
septic shock. Let's talk about septic shock. Yeah. And dude, what I need help with is I'm gonna be honest. When I talk to you about this stuff, you start listing these trials, and I just realized how much smarter you are than I am.
I thought you said
and
that.
So, like, yeah, a little bit. So tell me, go through the trials that matter, and more specifically than the trials, like, what do you actually do? What do you give steroids in septic shock? When do you give them? How long do you give them? What's your thought process?
Yeah, generally, I don't give steroids to prevent septic shock. So Hyper's trial looked at that, and steroids, hydrocortisone 50q6, does not prevent someone that's septic from going into septic shock.
Unless they have community-acquired pneumonia, then you do.
Too soon.
And I'm reaching for steroids in, I guess what I would define as refractory septic shock. So if I'm reaching for a second vasopressor, I'm adding steroids at that time. I do hydrocortisone 50q6. You've got two different approaches. You've got the French trial and approaches that looked at hydrocortisone and fludrocortisone. They showed a mortality benefit. Then you have Corticus and Adrenal that just looked at hydrocortisone that didn't show a mortality benefit. But all of those trials showed decreased time on vasopressors, decreased time on the vent, decreased time in the ICU.
All good things.
Yeah, absolutely. No matter what. Some did Cort stim testing, some didn't. But really, anytime I'm reaching for a second vasopressor in septic shock, I'm adding hydrocortisone 50q6.
And then this is just a question that there's no right answer to, but when is that second vasopressor added for you individually? Because everyone has their own. I know I have my own answer. When do you add that second vasopressor? Number?
Yeah, usually norepinephrine, 10 micrograms per minute based on the VAST trial. I think vasopressin in and of itself is interesting from a steroid standpoint. We've got V1, V2, and V3 receptors, right? V1 very much acts like a catecholamine receptor. It's a G-coupled protein receptor, increasing cytosolic calcium, and you're going to get peripheral vasoconstriction. But the V3 receptor actually is going to stimulate the pituitary, increase cortisol production. So you're also getting increased steroid endogenous production with vasopressin. So the mortality benefit we see in vasopressin, is it due to the V1 receptor, which in all catecholamines? Maybe not. Maybe it's the other effects that we're seeing with the other receptors.
Yeah, thanks. How about you, Adam? When do you?
Yeah, I think I agree. I think I start vaso at 0.15, and and honestly, or at 15 rather.
Yeah.
And I think it's just easy to teach the house staff.
Yeah.
If you're ordering vaso, order steroids.
Yeah.
It's just like an easy thing to think about. So that's how I do it. And I guess we should clarify is that we're using 10 micrograms per minute. That's probably atypical of most of the people who are doing it per kg. So like about 0.2 of norepinephrine is about where we start, where I started.
Yeah.
But then I have a hard time tapering and knowing how to do it.
Yeah.
So let me hear you first so then I can disagree.
He's always so pleasant to our guests. That's why no one comes back.
I usually give them a day after being off vasopressors before I'm starting to taper the steroid. So once they're off vasopressors, I leave them on 50q6 for about a day.
Yeah,
and then the next day, if I'm going to taper, I'll start tapering. If they've only been on for, let's say, 2 to 3 days, I'll just cut it. But if they've been on steroids for 5 to 7 days, I'll do a slow taper. Never dropping the interval of hydrocortisone to less than Q12. Because at that point, like we were talking about with the half-life, you're just not getting the
It
effects.
makes sense.
Yep.
Yeah, I do the same thing. And like sometimes we don't think they're in septic shock anymore. We think it's the propofol. That's why they're on pressors. And I just leave them on because what inevitably happens is you stop the steroids and the next day they're on like double the dose of Levofed. And it's also because they're adrenal insufficient or is it because what's going on? And then you're like, oh, let's restart it. So I just leave them on until the vasopressors are gone.
Completely off.
Yep.
Yeah, interesting. Yeah. Yeah, I don't always taper, to be honest with you. If I have somebody who, it's a kind of two-sided answer. There are patients who, they go on vasopressin. So let's say they're on 15, right, of levo and norepinephrine, and then you start the vaso, and then they just drop right off, right? Wow, I was not expecting that. There's some people who are vasodeplete, and they just really respond well to it. Those people, that kind of tells me something about their physiology. So that's the first thing. And then if they really rapidly come off the vasopressors, at least one of them, if they come off like the vaso, I'm actually okay stopping the steroids. Some of them will hang around for a little bit of time after that. But yeah, it really depends on the patient. If the patient really came out of a lot of sickness and stuff and they've come a long way, I'm not so quick to take off those. Sometimes other people on the team, the pharmacists, will want to get the steroids off. And I get that. It's good stewardship. But I'm like, look, I don't have any evidence for you, but please, let's just keep this on for a little longer.
Yeah. I think I think the takeaways, it probably depends on each patient.
Yeah.
And you got a 90-year-old who's on the vent and frail and weak to begin with. I'm not giving her extra steroids unless I have to. So I think that's all good. Cool. So what do we say, yes or no?
It's a yes for me.
I don't.
No?
No, I don't. Yeah, you saw the mortality difference between approaches in the French trial versus Adrenal and Corticus. There's probably a couple different reasons why that could have been. There was more pulmonary sources of infection with the French trial and approaches than the other one. So maybe it is that kind of the effect of the community-acquired pneumonia or the pneumonia as the source. But there was also Coetzee, which was a trial looking at insulin and septic shock, and they compared fludrocortisone and hydrocortisone versus just hydrocortisone. No difference between the two. So that's why I'm not really reaching for fludrocortisone.
How about you, Adam?
I don't know. I'm going to give the lamest answer ever. I just think I'm indifferent to it. The approaches to me is not a helpful trial at all because they compare to placebo, which I believe in steroids and septic shock, and so that's not a reasonable comparison group. I think if they come in this patient who has rip-roaring sepsis, clearly from gram-negative bacteremia, and I would do it. But I think sometimes they have pneumonia, they get intubated, they're relatively clinically stable, and they're on 15 of levo, and they're not like crashing. And I'm like, there's a lot of things at play here. Some of it's sedation. Maybe I just do hydrocortisone. But I think, so I guess I do both, which probably means I'm definitely wrong in one of them. And sometimes you have that member on the team that's, we got to do fludrocortisone.
Yeah.
Like, all right, fine, then do it. I don't have enough to argue with you.
Are there downsides that I'm missing to the fluid, except
fluid,
nursing time and
fluid retention? Sure. I mean, theoretically, fluid retention. We want to get rid of fluids. Also, maybe once again, I'm probably just not smart enough. What's the physiology? Like, why would fludrocortisone help? Like, I get the anti-inflammatory of hydrocortisone. I get the adrenal insufficiency aspect of it. But what is fludrocortisone doing from a mechanistic standpoint that would help?
Hydrocortisone, you're also getting the mineralocorticoid activity that you would
get some. You get some
fludrocortisone.
Yeah.
No, I agree.
So that's the reason. But you're also right. Is what's really the downside?
Yeah.
And my practice is more in line with you. If somebody's adding fludrocortisone, I'm not going to take it off. But if it's just me, I'm not adding it.
Okay. Cool.
All right. More to come.
Another case?
Yeah.
All right. Is this gonna?
Oh, you're gonna like this one.
I don't know if I will. A picture's worth 1,000 words, and yes, they are prone.
Now we're talking.
That's just the case.
That's the whole case.
This is the transfer. You get
chest X-ray. There's like the majority of the screen.
I get it.
Cool. So ARDS. So I just figured if I didn't say they're prone, that's the first thing you would ask me is, are they prone?
Yeah, I know.
have to say yes.
I know. I saw a patient that was under your care that was not prone with ARDS. I'm just kidding. That never happened. That never happened to ever.
Concerning. ARDS, steroids. What do we do?
So this is another topic that's gone back and forth. So you had Maduri that showed mortality benefit in ARDS with PDAF less than 200 with a long methylprednisolone taper. And then you had the Lazarus trial that came out looking at late addition of steroids in ARDS that showed actually worsening outcomes if you did it after day 14. And then ARDS came out that showed a mortality benefit. And I think mechanistically, when I think about it, it makes sense, right? So the thing that we're worried about with ARDS is fluid retention. Lungs are desert organs, they want to be dry. Dexamethasone not having that mineralocorticoid activity mechanistically makes sense. And so when I think about it, I like that aligns. And then dexamethasone, much like we use phenobarbital for alcohol withdrawal, it does its own taper given the long half-life. ARDS definitely won me over more definitively than community-acquired pneumonia. So basically, any patient that's coming in with ARDS, PDAF ratio less than 200, I'm doing dexamethasone.
Yeah, and it's so simple, right? It's 200 milligrams for 5 days and then 10 milligrams for 5 days. And so I do too. I think my question is ARDS non-pulmonary source. So that pancreatitis patient that has ARDS, definitely dexamethasone, dex-ARDS, we do it? Because I think the answer is yes.
Yeah.
But it adds a little complexity to it.
No, agreed.
And yeah, go ahead.
No, I was going to say too, and this might just be mostly anecdotal, but I find that the non-pulmonary sources of ARDS tend to be a more severe phenotype than the pulmonary sources. I'm definitely reaching for dexamethasone in those patients.
Cool.
Yeah, to me, if you're saying, because if I'm going to be on team steroids for the lung stuff, then we're giving it for that and the ARDS. And then for the same reasons that we're giving it for the ARDS, I would give it for the non as well. And I agree. Is there data that shows that the secondary ARDS is more severe generally? Do we have data on that?
I'm not sure.
That's my feel. I agree with you.
No, absolutely.
I totally agree with you because some of the worst cases I've ever seen, actually one case, it could be another lounge completely, is a gentleman who I saw in fellowship with pancreatitis that became necrotizing and then just went to the worst abdominal compartment syndrome, Florida ARDS, and just the sickest person I've ever seen. So my sense is, when it really gets secondary, it spirals really fast. Yeah. So.
Yeah, I think the answer is yes, too. I just was just bringing up that I do think that there's two buckets of ARDS.
Yeah.
We tend to always, the most common cause of ARDS is pneumonia, so they almost always are that.
Sure.
But like pancreatitis ARDS, it is a different beast.
Oh, yeah.
There is a different tempo to it than COVID ARDS, for example.
And I think these trials, like anything in ARDS, right, the earlier you do your intervention, the better the outcomes are going to be. Because what we're really trying to do is prevent going from exudative phase to the fibroproliferative phase, right? Steroids, you want to stop the macrophages from activating. You want to stop the recruitment of neutrophils. Proning, if you wait longer, you're actually going to cause worsening VQ mismatch than you would have had. ECMO, we're all part of the ECMO team. The longer you wait to put someone on ECMO, the worse the outcomes are going to be, especially at that 7-day mark. Someone did some research on that, I think.
Let me get up. Firth had some good points here. They were going back to the steroids in septic shock.
Mm-hmm.
Possibly coming soon, adding methylene blue for 3 days.
Oh, yeah.
You're going to have something to say about that.
No, Bonk just loves methylene blue, so
I do.
for it.
Do you?
I do. No, yeah, first referring to this one trial that looked at the early addition to methylene blue in septic shock and getting patients better outcomes off vasopressors faster. So yeah, I'm checking G6PD on patients more frequently now when they come in with septic shock than I was previously.
And are you giving the methylene blue like early once you find out like they're on vasopressor refractory shock? You're saying the G6PD and deciding?
I don't think much like steroids and community acquired pneumonia, I haven't exactly incorporated into my practice yet,
Okay.
but it's definitely for all patients, but definitely something I'm thinking about.
Something to think about. Okay. And then Firth.
And Firth also loves methylene blue.
Yes, he does.
It's cool when a pharmacist is into it, right? Because
Oh, yeah.
they're actually the ones who are mixing it.
Yep.
And if you've ever seen when a pharmacist is mixed methylene blue, it's like on their nice clothes,
Oh,
it's on
yeah.
their hands for
Yep.
days. But so a pharmacist that's into it, like they really believe in it because it screws up their day.
Absolutely.
Yeah.
And I have to give a shout out to fellow lounger, Dr. Bowden, because he did allow me to pick his brain this past weekend about steroids a little bit. So
Nice.
thank
We should have Firth back on. Didn't he do the show with Matt Salzman?
Mhm.
They did 2 shows,
Yeah.
right? And both of those were like,
Yeah.
people loved them both. They
Yeah.
just, and Firth is like just a fascinating person.
Oh, yeah.
Yeah.
I think it'd be cool.
I've
We
never
talked
met him.
about doing the like high top table, and so
Yeah.
if we could find a spot, because we can't do 4 people here, but that would
High
be super
top
fun.
table. Yeah. Yeah. It's on the budget, Adam. All right. This is a free show, but we'll look into it. Firth also says, I'm with Mike for no fludrocortisone. Plus, it's only available PO and multipressor shock. Gut absorption is limited.
So they come back.
Oh, is that? I don't know. I feed the gut. Even
I'm just
when
happy
they're really sick.
Firth agreed with me.
It's a win. What else do we got?
Glycemic control. I guess we were going to talk
Yeah.
a little bit about that. I'd go to the insulin drip pretty quick.
Yeah,
And on tons of steroids, I just put them in insulin drip.
Some of the septic shock trials too. Adrenal, I think for sure, used a hydrocortisone infusion, not the 4 times a day dosing to try to get better glycemic control. I don't ever do the continuous infusion, mostly because I don't want the nurses to be mad at me.
Yeah.
I don't know if you guys ever consider that as opposed to the Q6.
No, I just
Yeah,
go
we
with the institution. You know what I mean? I try not to be that person who's all Mallemat, like sticking to But if I could design my own ICU and have it that way, I would do the continuous infusion.
Mhm.
And I would also have a much lower threshold to put people on insulin drip. I just think the
Yeah.
control that you get is so precise, but I can appreciate just how taxing it is on the nurses. And with our state of healthcare right now, the last thing you want to do is just set another nurse or even just put a strain on the system.
Yeah.
But yeah, if I could design my own ICU, everything would be perfectly controlled. Yeah.
And I think that the disease process too is something that's going to make me reach for the insulin drip a little bit quicker. So if it's a patient with pancreatitis, for instance,
Yep.
like those
Yeah.
are patients I'm reaching for
Sure.
the insulin drip, like maybe right off the bat, just to
Yeah.
make sure you got that good glycemic control.
Yeah. Cool. Do we have another case?
There was one more, but yeah, we can do it.
If it's going to insult me, I'm
No.
sure you want to see it. Oh, there's no insulting of me?
No,
Well,
I
then,
ran.
a 32-year-old female is allergic to pet dander, presents
I just wanted
intubated.
to say dander.
Call to the ER for hypoxia. Her chest is quiet. All right. And then
And I will tell you,
the
if
little
you try to look for a waveform of air trapping, it is very hard to find one.
Really?
Yeah. So I had to just do this one.
You don't know how to draw?
Thanks.
Come to me next time before we do these shows. I'll help you out. All right. So you have that. And let's go back and let's just point out for maybe the students on the show or the residents who aren't familiar. I don't know if my mouse is working, or if it's going to work. Oh, it is working. Look, what do we think about this right here? That's the air trapping. So this is your inspiratory waveform. I'm trying to get my mouse sorted out here. So your inspiratory flow, right? Square waveform. So this is a volume mode of ventilation. And now this is our expiratory phase. Normally that should come up right back to baseline at 0 flow, which is right here. But before we're able to get to 0 flow, another breath is initiated either by the patient or by the machine. And we're seeing that this little bit over here is causing air trapping. Yeah?
Yep. So just showing a case of status asthmaticus or obstructive lung disease.
Yeah.
And so I guess asking your thoughts on what steroids you use, how much you use. We know you do it for 5 days.
No, not with asthma.
Oh, sorry. Tell me about that.
But talk about like one of the scariest disease processes we see. That's one of those situations when I'm talking to trainees, like Usually I'll say, see the patient, come up with a plan, give me a call.
Yeah.
But if it's status asthmatic patient on a vent, I want to call
We
immediately.
go together.
Yeah, absolutely. Absolutely.
Yeah.
Besides like the ventilator management and things like that. And the breathing treatments, I'm doing 60 milligrams of sodium medrol Q6 pretty much across the board. Although there's so many different steroid regimens that people have chosen for status asthmaticus, I don't know if I've ever seen one that's superior to another one.
Yeah, I don't know. I think I do 40 Q6 or I don't know if there's a difference, but yeah. And then how long do you go just until they stop wheezing?
Usually, so more looking at their if they're on the vent, looking at their vent mechanics. So once I start to see objectively that you're getting resolution of the obstructive disease, particularly air trapping, you're not concerned about hemodynamic collapse or anything along those lines, then I start to taper. So I don't do just 5 days and then cut the 60 Q6. Yeah, then I will agree with you. I start tapering at that point.
Yeah, and I think did we talk about status asthmaticus? I feel like maybe we did.
I feel like an early show. We
Yeah,
probably
maybe
should
early.
talk about it again.
That'd be a good episode.
Yeah. Because I think at that time that was pre-ECMO program. And now that
Yeah.
we have an ECMO program, we've taken care of some patients who have had some pretty big wins. I think it'd be worth talking about again.
I love talking about isoflurane and inhaled anesthetics for that in that setting. And
Yeah.
this thing is really neat.
Yeah.
So
All right, we'll do a show on that.
cool. What do you think?
So I have another, I know we're getting on the hour, and please start throwing in your comments now because there's a little bit of a delay. Throw in your comments now or questions or comments so we can start answering them. But I have one case that I thought about on the way over here, and this is a person who comes in to the emergency room who's developing anaphylaxis from whatever, right?
Mm-hmm.
And they get epinephrine, they get steroids initially, and now it's time to send the person home. Let's say the ED decides to send them home, and I'm asking you to put on your emergency medicine hats. Steroids for that person for the rebound that happens, or no steroids?
That's a good question. Probably would. Yeah.
Would?
I have no idea.
Yeah.
Yeah. I don't have an emergency medicine hat. That's the only problem.
Yeah, and so that literature is actually shifting, and it used to be that you would because you're worried about this biphasic reaction happening at 48 to 72 hours. And while there aren't randomized control trials that have shown this kind of prospectively, there's been a lot of meta-analysis and systematic reviews that actually shows that rebound isn't protected from steroids. And I think the UK is like the first, someone correct me if I'm wrong on this, but I think the UK is the first organization that's put out that for anaphylaxis, they don't recommend steroids on discharge. You can give your initial steroid dose, you're going to give them epinephrine, but no steroids on the way out, which I find interesting. I can't wrap my brain around the physiology, but I guess it's just that first hit, get it under control, and then that's it. So there's, for the anti-steroid people out there, there's something for them. And maybe Firth will, or anyone else can make a comment on that. Oh, I see someone in the audience. You know who it is?
Randy?
It's Randy. All right. Let's see what Randy has to say. My emergency medicine hat has a CT scanner built in.
He never disappoints.
I don't know what that means, but I like it. Let's see.
The big hat.
Big hat. Farhan, what's up? Good to see you. Lots of time these ARDS patients may have septic shock and usually need mineralocorticoid. All right.
So for the fludrocortisone believers, you say if you're in septic shock and ARDS, are you giving Dexa ARDS plus fludrocortisone, or are you not?
Not, but I'm also worried about that fluid retention in those patients that have ARDS.
And another kind of a side step from that question too is you have a patient who's in septic shock. They get put on 50 Q6 of hydrocortisone. They develop ARDS. What are you doing with the steroids? So
that's a good question.
For me,
no one asked you.
Dexa.
Adam, what do you do when that patient who you have with septic shock develops ARDS? I know you have thoughts on it.
I just can't come up with anything witty.
Just tell me what you would do. Tell me what you would do.
I do Dexa ARDS because it's more.
So you flip over.
So I just switch.
And time zero is when you made that decision to flip over.
It goes to 20 milligrams for 5 days.
Gotcha.
I just go forward because, as I said, I think it's a bigger dose equivalent wise than 50 Q6.
Same.
And you don't have to worry about tapering it.
Yeah. It gets you off the taper.
Yep,
Like, don't worry about the
absolutely.
taper. That's fair. Farhan also asks, have you guys ever tried the Midori protocol?
Oh, go ahead.
No, you go.
Actually, that's all. I was going to pose this to you guys. What do you do for your ECMO patients? So you've done Dexa ARDS.
I usually stop. I usually stop. I think that there's the point of the steroids is for the acute inflammatory reaction. And I know some of the studies use, we don't do it clinically, and I put CRP, but I do think it's interesting that if you were to check CRPs or inflammatory markers, my guess is the ones that are sky high are the ones that respond better to steroids. it's so nonspecific that clinically it's really challenging. But yeah, I stop and I don't keep the steroids on because you've left that acute inflammatory phase and are more in the just wait and do no harm and allow the lungs to recover phase.
I completely agree. Yeah, it's that 5 days of the exudative phase that you're really trying to modulate. And the reason that was my response to that question is because that's where I've seen the Midori protocol used the most was in our ECMO patients.
Yeah. So I don't do it. I think we did it in scenarios where we were desperate and they weren't getting better. And I will shout out to myself that we just published in Critical Care Medicine looking at long-run VV ECMO patients. And once you hit that 30-day period, that your mortality doesn't increase and that you just have to wait. And so I do think the lungs' natural ability to recover is strong enough that you just need to support and avoid complications, and that giving more steroids isn't necessarily going to help.
Can I ask you a question, Bonk?
Yeah, please.
Do you find it weird when people shout themselves out
All
on
the
a
time.
podcast? Yeah, okay.
It's awkward.
It's weird, and we just have to smile and nod politely. All right.
Did you know I did research?
Do you do research, Adam?
I didn't say it, man. You're the one who keeps saying it.
Ziptane, what's up?
What's it? Yeah.
In a patient with influenza or severe community-acquired pneumonia, when would you not give steroids? Are there clinical situations which you consider as contraindications to steroid use? Question.
What do you got? Hypersensitivity to methylprednisolone is number one on my list.
Influenza. But that kind of goes back.
No, it's a great question. So who do you not give it to? I think that there are, how about severely immunocompromised? Would you, like patients that are like bone marrow transplant, or that, do you worry about those patients?
Still, a short course of steroids has not been shown to increase your immunosuppression to the degree. I would definitely try to get them off of it as quick as possible, avoid the prolonged taper. But yeah, as far as I'm aware, a 5 to 7 day burst should not increase your risk. How about you?
Yeah, I'm just trying to think about it. If you look at the trials, all the exclusion criteria are things like those with bad obstructive lung disease already on steroids, those that are DNR, all things that don't apply clinically, but that are excluded in the trials. I don't know if there is any strong I'm sure there are if I really look. But I can't, nothing comes to my mind.
Because I think we were talking about before, a lot of those things that we were afraid of from earlier trials just really haven't panned out in recent ones.
Yeah.
And the earlier trials were using crazy doses for crazy amounts of time. I was going to make a comment about Midori, but like Midori is like one of those protocols that's always was constantly trying to find it since I was a medical student, which was 75 years ago, Adam. Midori has been trying to find
55 years ago. You didn't start medical school when you were born.
No, I'm 92.
Oh.
I'm 92.
You look good.
It's the cream and the nightly routine that really keeps the skin so soft.
Oh, shout out to your sponsors.
Oh, yes. Thank you, Suavecito. I'm still looking for sponsorship if you have any availability. And I use your product 3 times a day, and it keeps the shine and the bounce really nice. So Suavecito, if you're looking for people to sponsor, I'm in the DMs. Firth has something else.
Been working on that.
Yeah, it's good.
I believe they're going to sponsor me, by the way. I tag them in videos, and they see them. I read them in my story. They're going to sponsor me. You mark my words. $30 a day to do this hair. If I can get a sponsor, my kids will be able to go to college. I believe there's literature that has looked at dexamethasone in septic shock, and Dexa reduced 7-day mortality without adding mineral corticoid. This was done in the hydrocortisone shortages. I'd love to, if you have that reference, you don't have to put it now, Firth, but I'd love that reference if you have it, and we'll share it with everybody. Yeah, that's really cool. Because dexamethasone does not have too much mineral. Interesting. Yeah, love to see those studies. If someone could just do some research on this, they would be very helpful. I don't have very much research.
Yeah. Do you know of anyone that we could?
I'll have to scan through the database just to see who we could find. But if someone could do that, would be wonderful. Someone who's like part of their FTE is actually for.
So I'm sorry to interrupt you.
Right.
This is probably a good time to announce it. This will be my last show. I will be retiring from this show, given the.
Are you looking for co-hosting? Are you looking for a show to be part of?
I've got
because you got
already been
really
replaced.
charisma on very tall.
Yeah,
very tall, 6'3" and change. This guy.
If I could get some skin product endorsement,
we're working on it right now, actively. Folks, we ran a little bit over, but what a fun show! What a fun show this has been. Michael, thank you for being here with us.
Thank you guys for having me.
Appreciate it. Still to this date, the tallest guest on our show and one of the smartest.
That's true.
No, I think it's true. And certainly one of the more controversial ones that we've done to date. Yeah, it was a good show.
We talked for an hour and probably got nowhere. But
And here we are, still not sure what to use with steroids, but we have some good ideas. And Firth and Tane and Farhan, thank you for your questions. And this will be available for replay in a day. We're going to just edit out all the nonsense and make it available. So don't forget to like and subscribe. If you enjoy this, we're going to be coming back probably in about 2 weeks to do another show.
Yep.
And I'm going to give a shout out to myself, because apparently you can do that now. If you haven't registered for the ResusX Trauma Conference, that's going to be next Wednesday. So go to resusx.com and register if you haven't already. It is a one-day virtual conference, and we have tons of great speakers. And I think it'll be very enjoyable. And then ResusX is coming in Philadelphia, September. Keep your eye out for those dates. Sorry for the self-promotion. Gotta do it. Gotta keep the lights on.
It is your show.
These lights don't pay for themselves, so we gotta find a way. But thanks for being here.
Absolutely.
And Adam, thank you for being the
It's a new addition, the handshake. I like it.
You like that? We should do that every show. I was thinking about doing like these slaps because my kids and I work on these slaps, but I don't know. It's just not our demographic.
We just do the handshake.
I will just do the handshake. All right, thanks everyone. I'm gonna leave with this.